focused in improving genetic services for the transgender and intersex community, particularly within the cancer and prenatal clinical spaces. She co-leads a virtual process group for LGBTQIA+ genetic counselors and students, and has advocated for this group inclusively through talks, blogs, podcasts, and research articles. She was awarded the Association of Genetic Counseling Program Directors Outstanding Clinic Supervisor Award in 2021 and the National Society of Genetic Counselors Leader in Culture Advocate Award in 2022. So here, the floor is yours.
Thank you so much for that kind introduction. I'm nervous, but excited and privileged to be here presenting alongside Janine. Again, my name is Kim Zahowski. I use she, her pronouns, and today I'm going to talk about gender-affirming genetics practices. I have no conflicts of interest to disclose. Of note, I've given this presentation several times with my collaborators, Tala Barrow, Hannah Lauren, and Kellen Baker, and would like to thank them for their contributions. Before we begin, I wanted to give you a sense of my positionality and the lenses that I'm coming into this presentation with. Our lenses really shape how we learn and think about the world, and also how I'm presenting this topic to you. So I'm a queer, Vietnamese and white, non-disabled person in my late 20s. I'm from the United States and have spent most of my life living in Massachusetts. I'm a genetic counselor by training, which will really come across in this presentation. And I'm really passionate about queer advocacy and anti-oppression, and that is what has propelled me to work in this space within our field. And to start with on this presentation, I wanted to start with this quote by queer activist Erica Hart. It says, "Empathy does not guarantee or assure that someone is going to care enough to do something, especially if they need a framework or word to do it." How I take this quote is, I feel like I hear all the time genetics professionals talking about how their empathy is what drives them to be culturally competent and humble providers. However, I want to argue that empathy alone is not enough to best take care of the transgender community. There are tangible tools and knowledge that we need to gain in order to make sure that we are truly culturally humble providers. LGBT culture is far from a recent or Western phenomenon. Fluidity in gender, sexuality, and our performance of these roles has been evident in different cultures around the world, particularly before Christianity and the Western influence spread. For example, in Southeast Asian culture, non-binary gender identities have played an important role for over 2,000 years with hijras. In Native American culture, there are people who are two-spirit. Queer love has been represented in ancient Egyptian tombs. The gender binary is rooted in Western colonization and Eurocentric thought. Cultures have had more than two genders, porous boundaries between genders, or no genders at all. And I would be remiss to talk about queer healthcare without thinking about the landscape of safety for LGBT people across the world. Right now, there are 66 countries that criminalize being LGBT. Last week, there was breaking news that spread across the world that Uganda has recently implemented a death penalty for LGBT folks. I'm from America, and the Human Rights Campaign is a national LGBT organization that has declared a national state of emergency for LGBT Americans, because this year alone, in 2023, there have been 491 bills proposed that are anti-LGBT. And more specifically, most of them are anti-transgender. There are things like bathroom bans, sports bans, gender-affirming care bans, bans from talking about LGBT identities in school, bans that really are prohibiting LGBT people from living in public life. And while not all these bills are going to pass, they all pose significant detriment to LGBT people. I was looking into laws throughout Europe and recently discovered that there are 9 countries throughout Europe that allow forced sterilization of transgender people who want to change their identities on their identification cards, which really just shows how our current systems perpetuate eugenics practices. So again, thinking about this landscape, it's really unsafe to be LGBT in this world. And when we're thinking about healthcare inequities, we need to shift away from individuals and towards systems as the root causes for healthcare disparities. The focus of transgender health disparities must be on the institutions, policies, and practices that continue to mistreat transgender communities. LGBT identities are commonly cited as a biological reason for health disparities, as opposed to cisnormativity, homophobia, and transphobia. This really parallels how race has been inappropriately medicalized to support racism and white supremacy. And when we're thinking about systemic changes, I want to emphasize that there are no quick fixes, and this work is very urgent. And in genetics in particular, I think there are a lot of different messages that we send that really reinforce specific myths or things that are not true. For example, I think that we sometimes imply that there's something wrong with LGBT people, that the higher rates of health concerns for LGBT people are related to individual genetic or behavioral concerns, that sex is binary and immutable, that sex defines gender, and that the fundamental truth of who you are lies within your genes. There are a lot of important truths that lie within our genetics, but when we're thinking about social identities, who we are, we also need to trust people. And I hope throughout this presentation we can help deconstruct some of these myths. And there's a lot of tension between the medical community and the LGBTQIA community. The medical community is made up of institutions that interface with other institutions like the government, research, academia. And there's a history, both current and historic, of institutionalized discrimination of LGBT people. The medical system has not earned the trust of our community. And I would say people do not owe the medical community their trust. It is something that we have to earn. The medical system tends to pathologize differences such as sexual orientation, gender identity, and sex characteristics. And some core concepts in LGBT culture are celebrating self-determination and existing outside of categories. The medical system really uses categories to figure out who needs care. And reasonably, the medical system looked toward the past for evidence in terms of how we should best treat people. However, this doesn't really work in this setting since LGBTQIA identities have largely been erased from recorded history. So next, I'm going to talk about some specific practices that we can think about to be more inclusive of the LGBTQIA community and more specifically the transgender community. I want to discuss clinical laboratories and how they can reinforce gender binaries. Test form requisitions and reports are often hotspots for inaccuracy and stress. I know some labs have started to include both sex and gender on their reports, but this can be problematic if a provider is assuming someone's gender and gets it wrong. Moreover, let's say if we do have a transgender person who's not out to their family, often we're sharing our reports with our family members, particularly if there's a positive result. So if a provider puts both sex and gender on the report, it could put that person in an uncomfortable situation where they're actually outing themselves to their family through their genetic testing reports. Another thing I've seen is some marketing for labs like the non-invasive prenatal screening test, calling it the gender test, or calling other tests women's health tests. All this might seem like a marketing strategy, but it has real ramifications in that it reinforces binary constructs of sex and gender. And if we don't even bother to use the correct terminology, who do we think will? When thinking about meaningful change in clinical labs, I want to shout out the authors of this piece, Gender Inclusivity in the Genetics Lab. They note how labs can consider limiting the demographics on their test requisition forms and reports to what is required. In the US, for example, that's by CLIA and CAP certification, which only requires 2 identifiers, date of birth and name. We don't even need to include sex or gender on our test requisition forms. These authors also talk about how reports should consider removing sex and gender from their interpretation sections and instead focus on the findings and the risk using more accurate information like sex chromosomes or organs present. Sex can refer to a lot of different things, and we need to be specific about what we're talking about. Are we talking about someone's sex assigned at birth? Are we talking about their sex chromosomes? Are we talking about their hormones? It's more accurate and more specific. So I've worked as a cancer genetic counselor for most of my career, and most of my research has been within the cancer space. So I'm excited to talk to you about this section. And throughout this presentation, I highlight a lot of qualitative research articles. I think qualitative research is a wonderful way to directly uplift community members' voices throughout research. You know, the transgender community has been silenced throughout history, and I think it's a really great way to bring their voices into our practice. This particular article is one where we interviewed transgender patients who had seen a cancer genetic counselor. It was a pilot study. Here's a quote from that study. I've had really bad experiences with medical attention before, where someone wasn't educated on trans people and clearly had never met one, and was having a consciousness expansion revelation while meeting me. For the trans patient, it's just dehumanizing and polarizing. Multiple inequities that exist that prevent transgender people from accessing cancer screening and care. Some of these barriers are societal, like lack of insurance or low socioeconomic status. Other barriers stem directly from the medical institution, such as medical racism, discrimination, lack of provider training, lack of appropriate screening recommendations. These systemic injustices result in transgender patients not accessing equitable cancer screening and care. Cancer screening guidelines focus almost exclusively on cisgender people, leading to the potential mismanagement of gender-diverse people. And there are no national cancer registries that collect data on sexual orientation or gender identity. This means that we can't even know the proper incidence rates for cancer among these communities. However, what has been studied is that LGBT people are less likely to have cancer screenings. More specifically, fewer transmasculine patients have cervical cancer screening like pap smears compared to cisgender women. In general, transgender patients are less likely to receive breast cancer screening, colorectal cancer screening, and prostate cancer screening. Additionally, LGBT people in general are more likely to have poor outcomes from cancer. One really low-hanging fruit, or something I think we can all do pretty easily, is think about the gendered language we use within the subspecialty and think about how we can deconstruct that. For example, in some medical settings, you'll hear people talking about male organs or female organs, when it's just as easy and a lot more specific to name the organ. Similarly, one might say male hormones or female hormones, when we can just name the hormone. And if a patient has questions about that, we can explain it a little bit more. You know, everyone has testosterone, everyone has estrogen. Neither is a male hormone or female hormone, and I think we can be more specific. And of course, as Janine said earlier, if someone uses a specific term to describe their body or an organ, mirroring that language is the most affirming. Here's another quote from that study. It's important to be mindful about talking about genitals and reproduction, especially when nonchalantly brushing past body questions, not to assume, because that could be triggering. We ask a lot of really sensitive questions to our patients in clinical settings, and I think it's important that we explain why we ask, so it doesn't just appear like we're being over-curious. It's also, this quote really demonstrates the importance of using a trauma-informed approach, because people can be really sensitive talking about their bodies for very real reasons, and also because of past discrimination. To get a little bit more into the genetics inequities, there have been numerous studies at this point documenting the specific issues in this setting. The first being that about 3/4 of genetic counselors have had no training on transgender cancer care. Additionally, several surveys have noted that there have been issues in genetic substance, such as transgender people being more likely to have disruptions with family relationships, which impacts risk assessment in the cancer setting. You know, because of stigmatization and discrimination, it's not uncommon for transgender people to have severed relationships with family members, which of course creates a healthcare disparity in the cancer genetic setting, because we might not be able to do a comprehensive risk assessment. Next, transgender patients have reported anxiety for genetics consults because of a number of reasons, one of which being a concern for physical exams. I don't know about everyone's practices, but I know in my practice as a cancer genetic counselor, I have never done a physical exam. And I think in our pre-work for patients, we can very easily have a note that says there will be no physical exam in this appointment, if that's the case. I think it also just helps prepare patients better so that they know what to expect. Patients are concerned about gatekeeping of their gender-affirming care due to cancer genetic counseling, which I'll talk about a bit more. And there are generally large gaps in risk assessments for transgender patients, particularly who have chosen to undergo medical gender affirmation, like exogenous hormones or surgery. I want to say that not all transgender people will choose to take hormones or will choose to have surgery, but for those who do, there's really unclear guidance about how that impacts cancer risk assessment or screening recommendations, particularly in the context of a strong family history of cancer, or if there's a pathogenic variant found. So again, these gender-affirming implications are a critical gap in what we have in knowledge about cancer care right now. For example, there are differences between gender-affirming surgeries and prophylactic risk-reducing surgeries. Top surgery is a colloquial term for a surgery that many transmasculine folks have, where they remove their breast tissue to make the chest more masculine presenting. And this surgery does not remove all of the breast tissue. That means that folks who've had top surgery still have a potentially significant chance for breast cancer. A risk-reducing bilateral mastectomy is a surgery that's done for cancer risk reduction, removing as much breast tissue as possible, for example, for people who have BRCA variants. So it actually might be quite important for someone who's considering top surgery, who has a family history of cancer or a pathogenic variant in a breast cancer gene, to have the testing before they have surgery, as it could impact the amount of breast tissue removed. For transgender people who've already had top surgery, there's really unclear guidance about what cancer screening could look like. And there have been, I've seen a bunch of cases actually of transgender people in this situation who developed breast cancer who didn't even know that was still possible, and their providers didn't know that it was still possible. There's also some uncertainty among providers and patients about what screening people need when they've undergone surgery. An example of this is a vaginoplasty, which is a surgery that can create a vagina for folks, sometimes transgender women, for example. This surgery does not typically remove the prostate, and many providers and many patients do not know this, that transgender women who've had a vaginoplasty could still develop prostate cancer, may need prostate screening. So this might even be missing from people's differentials when they're being worked up for cancer. Additionally, there's uncertainty with hormonal gender affirmation risks. There's no firm research or guidelines regarding the cancer risks of gender-affirming hormones. Yet despite this, clinicians have been shown to gatekeep hormone prescriptions due to a fear of cancer risk, which makes transgender patients less likely to seek clinician care for fear of losing or not being prescribed hormones. Most of the data we have right now is from cisgender women taking birth control. One study showed that some transgender patients come to genetics clinics seeking information on whether they have a hereditary cancer syndrome because it could help obtain insurance coverage for surgery. An example of this is often with a BRCA variant, people would be able to get coverage for a prophylactic bilateral mastectomy. A lot of insurance companies, at least in the US, will not cover top surgery for transgender people. And so people are actually coming into clinic hoping to have a breast cancer gene mutation in order to get coverage for this gender-affirming surgery. And I do want to emphasize that this does not mean that people are hoping for a higher cancer risk. This means that they're hoping for the gender-affirming care that they need, and really just shows a break in our systems. And finally, in general, cancer genetic testing is not recommended for minors unless it's medically necessary. However, transgender adolescents might have questions about whether they should consider cancer genetic testing before they considering gender-affirming care, if it helps to inform that care. If someone's considering surgery, like top surgery, for example, genetic testing might be important if there's a familial risk, as this testing, again, could impact surgery. That would certainly be a reason to test minors in this setting. For others considering hormones, it's a bit trickier. As we just discussed, we don't have great guidance regarding hormones and cancer risk, and so a hereditary cancer risk should not be a barrier for someone to get the hormones that they need. However, for some people considering hormones, maybe they're on the fence about hormones, and maybe it would affect their personal decisions based on how they perceive their own cancer risk. Maybe knowing about a hereditary cancer risk would push them one way or the other. If that's the case, genetic testing could then inform those conversations and that person's own perceptions of their cancer risk. Here's another quote from that study. "My transgender friends are just like, why would you cut off your breasts? You just got them. And they don't understand the cancer risk side. The BRCA groups that I'm a part of, they don't understand the gender dysphoria side of it and the implications of what dealing with gender dysphoria brings, especially when you're just starting." Switching gears a little bit, I'm sure you can all imagine how reproductive care can be really impacted by sex and gender norms. And I think it's an area that language plays a really critical role and that we can do a lot better. In general, transgender people face erasure, transphobia, homophobia, and violence in clinical spaces, and this is really magnified in reproductive care. Prenatal spaces tend to be cis-heterodominant, meaning that they tend to center on cisgender women and their cisgender male partners. Assumptions about relationships impact patient-provider trust, particularly when providers make assumptions about someone's gender or their relationships to their partners, for example. Many LGBT people might hide their identities in clinical settings for safety concerns. Moreover, transgender people have reported a plethora of mistreatment in the prenatal realm, illustrating why they might be distrustful or avoidant of institutional health care. Much discrimination in the prenatal setting surrounds providers' interpretation of who is fit to parent. Transgender patients have been noted to been asked if they should see psychiatrists before they're allowed to have children, or being threatened by medical providers to have their children taken away. Many states, at least in the United States, have laws that prohibit adoption agencies from allowing same-sex couples parenthood. This discrimination showcases how eugenics is still very prevalent in medicine. Pregnancy can trigger discomfort for transmasculine and non-binary folks for a number of reasons, some of which are clinic-based. For example, obstetrics and ultrasounds clinics are really socially coded as feminine spaces. Misgendering happens a lot more frequently when people are pregnant, and gender-diverse people might choose to pass as cisgender women or cisgender men for safety in their personal lives, which can be really hard in a prenatal clinical setting. There's one striking statistic that in the United States, about 22% of transgender people choose to have home births as compared to 1% of people in general, which really showcases, again, people avoiding healthcare systems. Pregnant transgender men might have questions specific to gender affirmation, whether they will be able to chest feed, for example, after top surgery, or the impact of testosterone on pregnancies. Some people will be able to chest feed. It depends on the surgery, and that's actually a great question for surgeons. There's really limited data on the impact of testosterone on pregnancies. Many providers tell trans men inaccurately that they might not be able to, or that they would not be able to get pregnant while on testosterone, which is just not true. And so some transgender patients may falsely believe they can't become pregnant while on testosterone. Again, I want to showcase qualitative research throughout this presentation. This particular study isn't genetics related, but it does showcase the experiences of transgender men who've experienced pregnancy in the healthcare system. Here's a quote from that study. A transgender male seeking pregnancy was too new or too different for them, and they didn't have studies to look at. They didn't know if it was safe, none of that. So I think that they were afraid of helping and getting it wrong, in addition to feeling uncomfortable. I was intentionally trying to fly below the radar. I wanted to be able to present as male, but I made the decision to present as female because I was afraid. I never really wanted to do a home birth. I was only going to have to do a home birth out of fear of how the hospital wouldn't be able to deal with me. Again, some low-hanging fruit. I think there's a lot of language that we can change in our pamphlets and how we introduce concepts to patients that are gender neutral, to replace gendered terms until a patient tells us what terms they use or showcases what terms they use. Some of these common gendered terms are as simple as mother, maternal, pregnant women, husband, wife, father of the baby, women's health, when these terms can really be easily replaced with gender neutral terms like parent, donor, parental, pregnant person, partner, reproductive health. And of course, if a patient uses language to describe themselves, their partners, their bodies, their experience, mirroring that language is the most affirming thing to do. Something I think about a lot recently is how we talk about sex chromosome screening in the prenatal setting, such as when we're doing non-invasive prenatal screening. And this is just a blog post about some of the things to consider when we're thinking about sex chromosome screening. Often you'll hear providers say it's a boy or it's a girl, which really reinforces cisnormativity and the misconception that sex chromosomes equal gender. Suggesting that sex chromosome screening can determine gender is harmful because it reinforces bioessentialism, or the belief that an individual's characteristics are exclusively defined by human genetics. Bioessentialist arguments have bolstered eugenics, racism, sexism, homophobia, and transphobia. The misconception that gender, a sociocultural construct, is determined by sex chromosomes erases the experiences of transgender and intersex people. Conflating sex chromosomes and gender in a prenatal setting is not only reductive and harmful to the communities that we serve, It's also just inaccurate. Genetic counselors rarely speak in absolutes. Often we'll say things like when discussing negative carrier screening, we might say things like, oh, there's a reduced chance for the pregnancy to be affected, to acknowledge that there is a residual risk that still exists to the pregnancy, even if it's as low as 1 in 10,000. This level of specificity is lost when genetic counselors say it's a boy or it's a girl based on NIPS results. These statements are just inaccurate. Another thing that I think about is how with non-invasive prenatal screening, more and more people are using genetic technologies to select against sex chromosome aneuploidies and intersex traits. I'm going to preface to say that I am very much pro-choice. I think that people should always be able to make decisions about how they go through pregnancy and about their bodies. However, I think the way that we talk about intersex traits and sex chromosome aneuploidy can be very problematic, particularly when we're talking about heteronormative or cisnormative concepts. Nothing we say as genetics providers is non-directive. Everything we say impacts patient decision-making. So I think we really need to be critical about what we're saying to patients and how we're saying it, making sure it's accurate and making sure it's not just filled with our own biases. So there's an ongoing study right now, which is where we're interviewing transgender people about how they think we should be talking about sex chromosomes, particularly in a prenatal setting. This is a quote from that study. It's very important that healthcare providers use the correct terms when addressing the chromosomes of a person. The public is still going to listen to providers when it comes to matters of the health. Healthcare providers addressing this in an inclusive way means that the rest of the general public will follow in their footsteps. I think this is really powerful and really demonstrates that we as healthcare providers can be leaders in this regard. When I was talking about this different pieces of legislation in the United States that are anti-trans, many of them cite genetics as being a predictor of gender, and that's just not true. And reinventing those conversations or reinforcing accurate notions of sex and gender starts with us. We have a lot of power in this realm. And finally, I know a lot of folks here are involved in research, and I want to think about inclusive practices in the research setting. And first, I want to start with some studies that have been done in genetics. You know, the first gay gene studies, or looking for a gene that causes people to be gay, were conducted by Dean Hamer and his team in the 1990s. And these studies were heavily criticized as being used as a tool for pathologization and weaponization against the LGBT community. These studies inherently pose LGBT people as a puzzle, or even worse, as abnormal. And recently, we can see a lot more studies like this happening, like whole exome sequencing to try to find a transgender gene, for example, or GWAS studies looking for genes that cause people to engage in same-sex behavior. There's even a startup company out there that I think has since disbanded that said that they could analyze your DNA and see if you are gay. And I hope you can realize how these types of studies are positioning LGBT identities as abnormal, something to be explored, a curiosity, and positioning heterosexual or cisgender identities as normal. And before these studies were conducted, there weren't any studies that were published, at least, that explored how the LGBT community felt about this type of research being conducted. So I think you can see what I'm getting at. That is a research study that we did. We interviewed transgender folks about how they felt about trans-associated genetic research. That is research trying to find a transgender gene. And what I will say too is that in this study, people did see positive aspects of this type of research. They thought that it could be personally affirming. It could help them understand more about themselves. However, overarchingly, every single participant noted the negative outcomes from this research. They noted that genetic testing in itself is not harmful. It's just information. It's what we do with this testing that can be harmful and bolster eugenic sentiments. All around, the participants in this study thought that this type of research should not happen because of the potential for eugenics, weaponization against the transgender community, or needing a trans gene in order to access gender-affirming care. Here's a quote from that study. We should be honoring the natural variability of human gender identity. Trans-associated genetic research is framing the narrative for cis people that something was wrong with a trans person and that cisgender people are fixing it. My first concern is that by identifying that, if it's something that would show up before someone plans on following through with a pregnancy, is there a chance they would terminate based on sexual orientation or gender identity? So all in all, whenever we're considering any research about any community, we need to be involving that community in all aspects of that research project, from the research question, is this a research question that the community even cares about, to the execution of the research, the manuscripts, even the advertising for the manuscripts. And we only should be conducting research when it's both in the best interest of the community and when the research goals are shared by the community. We can't make assumptions about what communities need. We need to go to the communities to make sure that we're doing something that is something that they're asking for. We can't just be doing research out of curiosity, particularly when we're thinking about the ethical and societal implications of that work. And also, we can never truly necessarily control how our research is weaponized against people, but we can certainly try. We need to make sure that we have clear takeaway points in our research to mitigate the ways that research can be used for discriminatory purposes. All in all, I think about, too, a lot of how genomics interfaces with public policy. And I think that right now, we don't have the data that we need to best take care of the LGBTQ community. We need to collect, analyze, and report data on sexual orientation, gender identity, and intersex status in clinical surveys, public health surveillance, and population surveys in order to get that information, such as with cancer screening and care. I also want to underscore what Janine talked about earlier, the principle of gender by default. It's really important to understand and know someone's gender in order to best take care of them. And I'm not saying it's not important to ask about sex too, but when we're asking about sex, we need to be specific. What aspect of sex are we asking about? Are we asking about sex chromosomes? Are we asking about hormones? Are we asking about organ systems? Or are we asking about something legal, like sex assigned at birth, or on a birth certificate, or on identification cards? I hope that I've shown you throughout this presentation that we need to support both qualitative and quantitative data collection. Certainly in genetics, we hear about big numbers and how that's very important. Yes, that's true. But when we're thinking about community experiences, you can't distill people's experiences to numbers. I think it's really powerful for qualitative research, again, to uplift the direct voices of these communities that have been marginalized in our healthcare systems. Of course, we need to maintain high standards for privacy and confidentiality. We need to collaborate with the LGBTQIA community, and we need to publicly support protective laws and practices. So before I wrap up, I just want to emphasize some of the principles of inclusion that I've been talking about throughout this presentation. In many ways, precision medicine feels like the ultimate goal of genetics. And this can be a guiding principle for us to be more inclusive. Some questions we can ask ourselves are we ensuring that there's true informed consent for procedures and exams? Do our patients feel like they have autonomy and agency in their care? Are we ensuring personalized risk assessments that don't rely on binary frameworks of sex or gender? Are we mirroring the patient's language and not placing cis-hetero assumptions on their relationships or body? The next principle is depathologization and inclusive language. These go hand in hand, as we must start as a genetics community to move away from pathologizing language and instead use inclusive language. I think this is an area we have a lot of power. We've noted that normative expectations of the body have led to pathologization and medical harm. One of the most harmful categorizations in medicine is the category of abnormal. However, as queer activist Aurora Levins-Morales states, there's no neutral body from which our bodies deviate. Enforcement of binary categorization restricts individual freedom of expression for all people via unrealistic body expectations, gender roles, and behavioral norms. Binary frameworks of sex and gender have harmed people throughout genetics. And public policy actually uses our inaccurate binary language that we as a medical and genetics community enforce to bolster harmful legislation. So as a genetic field, we can be change makers in this regard in educating on the spectrums of sex and gender to the public. And if we ourselves use the appropriate language and terminology, then I hope public policy can mirror us. Here's another quote from that unpublished study. It says, medical professionals as a governing body should be releasing more statements to normalize the fluidity of sex and gender because they're seen as the experts. The longer this goes on, the more violence there will be. Rigid gender binaries kill people. It's really important for the medical community themselves to stand up and say something and normalize the fluidity and spectrum. And with that, this is my last slide. I hope some of you feel empowered because ultimately all of these institutions are made up of us. After this presentation, I want you to think about where do you have the power to rectify things? What institutions are you a member of? Are you a cancer genetic counselor and can you push for better cancer screening guidelines for gender diverse patients? Are you members of a genetics organization like ESHG or like NSGC who can push for more guidelines to be made? Are you part of a group that can push for a grant opportunity for research? Are you a lab GC and can you enact some changes in marketing materials or report language? And while you're doing this work of figuring out where your power lies, make sure you're thinking about how to uplift people who don't have it. This doesn't necessarily mean leaving all the change-making to a community that's already minoritized and burnt out, but it means figuring out where you can do what's clearly being asked for and do it. And when you do need a community voice, you can push for devoted time and money for those resources. So all in all, here are the myths that I hope we can debunk and say that LGBT people are a natural part of human diversity in sexual orientation, gender identity, and sex characteristics. Health disparities are driven by discrimination and other forms of structural violence. Sex and gender are both multidimensional, non-binary, and changeable. Sex does not define or determine gender, and at the end of the day, people know who they are, and we need to listen to them. Thank you.
Kim, I think I'm going to ask you to come over here for questions. And I really want to start by, first of all, thanking both of our speakers for some really incredible and empowering talks today. And in fact, that was part of the title of this session, was From Medicalization to Empowerment. And I hope that all of you in the audience are feeling empowered to enact some change as you move forward into your practices. And so I'm going to ask you to scoot down so we can actually see both of you really well in the image here. And I'm going to start by reading a couple of questions and invite people in the audience to go to the microphones as well if you have some questions. And to remind you all that, again, if you ask a question, we want to make sure we're doing it with that spirit that we talked about at the beginning of curiosity and open hearts and good things. But first, I want to start with a couple of questions from the online, and then I'll go to Mike 4. The first one, is there a way of sharing your pronouns while indicating that you're okay with other pronouns? What did the two of you think about this?
So I love this question. I'm so glad that somebody asked. I think that the simple act of sharing what your pronouns are inherently says that you're okay with other pronouns. So it's not saying these are my pronouns and they're the only acceptable ones. It's just saying, here's mine, what are yours? So, you know, if you noticed in the video I shared mine, I said mine are they, them, and my patient came back and said mine are she, her. And so I think just the simple question itself does invite people to know that it's a safe place, yeah, whatever your pronouns are.
And I think, too, some people are more comfortable sometimes starting out by saying something like, my name is Kim, I use she, her pronouns, what do you go by? It still opens the opportunity that the person can share their pronouns, but if they're uncomfortable to do so or don't know what that means, they might not answer with their pronouns, and that's okay, too.
Yeah. A couple more quick technical questions, maybe more for Janine, but certainly both of you. Someone also asks, does using AMAB or AFAB give the full story for sex? It is important to show aneuploidy in pedigrees as those who are assigned to sex at birth have a different sex on their chromosomes or their organ
Love
level.
it. And this question makes me so happy because it clearly demonstrates that somebody was really, really taking it all in. No, AMAB, AFAB, it does not tell the whole story at all. So where those letters come from, assigned female, assigned male at birth, that literally comes, as you all know, but let's say it out loud explicitly, from somebody at the birth event looking at the genitalia present on the baby and saying male, female, right? So as we've discussed, like that's only one way of assessing sex. There are many others, including chromosomes. So absolutely fantastic question. I think the question asker knows the answer, and yay them, yeah.
Do you want to add anything, Kim? No? Okay. One last question before we go to the audience. There have been a number of comments about using the language that a person themselves uses for affirmation, and I wonder, because there were a bit more comments than questions, if the two of you could just elaborate a little bit more on, you've both mentioned this multiple times, why we feel so strongly about this and how we can continue to do a good job at that.
I think a lot of this will come out naturally in conversations. Like, I think about the prenatal setting, if someone's talking about their partner, using the term partner.
Yep.
If someone's talking about their boyfriend, you can say the term boyfriend. If someone's referring to themselves as a mother, you can call them a mother. You know, I think that just using their language is just saying that you're listening to them. In the cancer space, you might, you know, maybe you are working with a transgender man, for example, and you might be saying things like, you know, we talk a lot about breast cancer risk in this conversation. What's the most affirming language for you? And they might say, and I might even say, you know, some people use the term chest, for example, just to give someone the freedom to not use the word breast. So I think there are a lot of different ways that this just will naturally come out in conversations. And starting with gender neutral terms until you know what someone uses for themselves.
Nothing to say. Beautiful.
All right, so I'm going to go to microphone 4 in the back, and then we'll come up to microphone 1.
Hello, I'm Emma Palmer. I'm she, her, and I'm from Sydney, Australia. Thank you for a brilliant session. Really, really enjoyed it. And thank you for the updated pedigree, because I have used that in my medical student teaching. And I must say that was the bit where they actually were engaged and interested, and I had lots of feedback. So I think it made people in the audience really engaged that this was being considered and carefully thought through. So thank you. I found your videos really, really helpful, how you explained how you talked about it. Is that available anywhere that I could share with my medical students? Or
Yeah, it actually is. Basically my team's website, I think if you Google me, you probably, nobody spells their name my way. So my team's website comes up, and basically all of our educational resources are available for free download from our website. So yes, it's a big long video. It's about psychiatric genetic counselling, and it's just little clips out of that I've picked. So yeah.
Hello, I'm Deborah Mascalzoni, she, her. I'm a bioethicist by background, and thank you. This was amazing. So I'm working with geneticists in population genomics, and I think we would really benefit from this kind of reflection while we are collecting really thousands of data about people and, of course, about gender and sex. So I was wondering whether you could think about, you know, a webinar series or something like that, maybe focusing on it. Because, I mean, to me, at least this was one of the first times in which I was thinking about genetics in a more nuanced way, because we hear about it really in a very binary way, right? So I think it would be fantastic if you could think about this. Thank you again.
Yeah, and I know there are a lot of fantastic webinars from the Fenway Health, which is a LGBT institute in Boston, and they have an educational website where they have how to collect this data and research, and a lot of informative webinars that at all levels talking about this topic too. I don't know if you have any more.
No.
Okay.
Hi, good morning. My name is Rudy, she, her, also from Boston, so hello. I just wanted to say, first of all, thank you for your talk. It was extremely informative and great to hear a new perspective as it relates to genetics. I just wanted to ask whether or not you know if there's any efforts or any existing sort of published guidelines that would really help us maybe have a clear distinction of what language to use when, and maybe sort of some contextual advice or suggestions for us.
So there are, I will say, within the genetic counseling field, if you're looking at anything genetic counseling specific, it's pretty limited. There's a really wonderful article by von Voppelklein, which is called Cultural Competencies for Transgender Patients or something like that, which is a really wonderful resource. If you message me, I'm pretty easily found. My last name is pretty uncommon. I can send you a bunch of resources, or any of you, a bunch of resources as well.
Thank you.
I'm going to go to microphone 3, and then we'll go 4 and 1 if we have enough time.
Hi, my name's Sarah. Thank you so much for those talks. They were really worth getting up for. I am from Liverpool Women's Hospital, and my pronouns are she, her. and I wanted to ask about responding appropriately. So I do try to use my pronouns routinely in clinic, introduce myself, and sometimes it isn't received well. Sometimes patients, again, say, I don't use that, I don't do that sort of thing, or even scoff, which, you know, totally inappropriate. And what I wanted to ask about was responding to that. And do you have any tips? Do you have any advice on that?
Well, I mean, so I'd be curious about what you have done. Like, what have you tried in those situations?
I've sort of said, I've kind of explained the situation. I've explained that, you know, people exist outside of the binary. People identify in many different ways. But yeah, is there more I can be doing?
So I think in those situations, I mean, so again, I'm just going to go ahead and say that there isn't a single right way to handle these things. And, you know, I think a lot of the time, honestly, genetic counselors fail to trust their clinical judgment to the extent that they should. So I don't know you, but I know the kind of training that you've had, and the response that you shared with us sounds perfectly reasonable to me, okay? So sometimes it's going to be, you know, safe and appropriate to sort of challenge somebody a little bit. Other times it's not. Other times you're just going to go, okay, moving on. You know, so trust your clinical judgment on those things, but just know that, like, I think it requires us to have a very deep sense of internally ourselves of knowing that we're not doing anything wrong, you know, by asking these questions, that they are legitimate questions. There's reasons for asking them. And yeah, you know, you can, I think explaining why you're asking is beautiful in a completely non-reactionary way. And then moving on. Yeah, lovely.
Thank you.
What would you say, Kim?
If someone feels a little bit unsafer, like say the patient's being more aggressive, for example, sometimes I'll just say something like, you know, it's a standard question we ask everyone, but you don't have to answer.
Yeah.
And I've just looked at the clock, and time flies when you have excellent speakers and conversations. So I'm afraid I'm going to have to cut off the questions and invite people to come up and ask separately afterwards. I really want to thank our two fabulous speakers for opening our eyes one bit more, and hopefully we can all go out and do better and continue to learn and continue to do better. And I hope you all feel empowered after this terrific discussion. So thanks for coming and for your attention today.